is the outline of my talk. First of all, I'll discuss what is menopause, what are the causes of menopause in women diagnosed with breast cancer, and what symptoms or problems may they experience, what are the options available to manage menopause, and where can I find further help and information. So what is menopause? Menopause is said to have occurred when a woman has not had a menstrual period for 12 months. Now this complicated diagram here just shows you the hormones that are released from the brain, the hypothalamus and the pituitary, which are the controlling hormones which act on the ovary to coordinate the release of estrogen from the ovarian egg cells during menstrual cycle. And what happens when menopause occurs is that there's a loss of these egg cells, and so we get a lack of estrogen, an elevation in LH and FSH, these stimulating hormones. The average age of natural menopause in Australian women is about 51 years. And this just shows you about that loss of egg cells that I talked about a moment ago. So we are born with about 1 million egg cells in our ovaries, and as you can see, there is an age-related decline in those egg cells during life, with a more rapid decline which commences around about the age of 35 and is associated with why we start to see fertility declining at that time. And menopause, menopause is thought to occur when there are only about 1,000 follicles left. Now, more rapid loss of these follicles, such as due to chemotherapy, so if you diagnose with breast cancer at 30 and the loss of egg cells because of chemotherapy, means that you might go through menopause at a younger age. So who of these women with breast cancer is menopausal? And the answer is all of them. So women can go through menopause when they're premenopausal through to older women who've already gone through menopause. So the causes of menopause and menopausal symptoms in women with a diagnosis of breast cancer is that it may be related to treatment, as I've mentioned, with chemotherapy, which can cause a more rapid loss of the egg cells, as we saw, or women may undergo surgical removal of their ovaries, called oophorectomy, as part of their breast cancer treatment. And obviously, if your ovaries are removed, you go through menopause at that time. Now, there are some women, breast cancer most commonly occurs in women over the age of 50, and so often women may be undergoing natural menopause occurring at the same time as when they're diagnosed with breast cancer. So the breast cancer per se hasn't caused their menopause, it's just occurring at the same time. For some women who are postmenopausal and have been taking HRT for their symptoms, when the breast cancer is diagnosed, they then need to stop their HRT, and that can cause a recurrence of their symptoms. And certainly we know that endocrine adjuvant therapy, so tamoxifen or aromatase inhibitors such as Femara or Arimidex or exemestane, can actually either precipitate menopausal symptoms or make them worse. I just want to talk about chemotherapy-induced amenorrhea for a minute. So amenorrhea just means absence of menstrual periods. And this can be temporary or permanent, and if it's permanent it would be menopause, stopping of the menstrual periods following or during chemotherapy. And it's very common. So up to in one study, 41% of women experienced 6 months of CIA associated with their chemotherapy. And other studies we know have shown us that up to 80% of women develop menopause before the age of 40 years as a result of their chemotherapy. Although this is probably a little bit less than earlier chemotherapy regimens because of the changes in the drugs that are used. The risk of developing CIA is related to age, so the older you are, the closer you are to the usual age of menopause, the more likely you are to develop permanent CIA or menopause. If you have a higher dose of chemotherapy or a longer duration of chemotherapy, you're more likely to develop CIA. And the type of chemotherapy. So chemotherapy regimens that include cyclophosphamide are more likely to, women are more likely to be associated with CIA than other regimens. Herceptin does not seem to have an effect on the development of CIA. At the moment, unfortunately, there's no reliable method of prediction. Anti-Müllerian hormone has been proposed, and there's certainly research to suggest that it could be useful. The problem is that there's problems with the measurement and the assays. So at the moment, we're not using it routinely to diagnose menopause or predict who's going to develop CIA. It is more usually used in the setting of women who, after a menopause diagnosis, after a breast cancer diagnosis and subsequently want to have fertility. It's used in the setting of predicting ovarian reserve and potential response to fertility treatment. There's certainly been studies, and the evidence is growing, that the use of a GnRH agonist such as Zoladex may be protective for chemotherapy-induced amenorrhea and menopause in younger women. So women may experience a variety of symptoms, and the symptoms shown here in red are those that are most routinely associated with estrogen deficiency. So hot flushes and night sweats, which are called vasomotor symptoms, urogenital symptoms, sexual function problems, and sleep disturbance are all associated with estrogen deficiency. The other symptoms that I've listed there can be experienced by women or are reported by women, but their association with estrogen deficiency itself is less clear. Certainly menopausal symptoms matter. We know that more severe menopausal symptoms are experienced by women with breast cancer, and the younger women have more severe symptoms than older women. And these symptoms have a major negative impact on quality of life and also can potentially impact treatment. So up to 20% of women with breast cancer consider stopping or actually cease their endocrine treatment due to the problems with menopausal symptoms. Now, there are a number of factors influencing menopausal symptoms. I've spoken about age and that they can be more severe in younger women. In relation to the cause of menopause, women who have a surgical menopause, so that their ovaries are removed, tend to have more severe symptoms than women who have a spontaneous menopause. Hotter climates are associated with worse menopausal symptoms. Women in my clinic prefer the winter compared to the summer. There are lifestyle considerations, so spicy food, alcohol, caffeine, stress can all impact potentially on women's menopausal symptoms, and if they have other health issues as well. Attitudes to menopause and aging, the cancer treatments, and I've discussed the endocrine adjuvant therapy. Psychological health and psychological issues can also impact on menopausal symptoms. We know that depression and anxiety can impact on the menopausal symptoms, and then the menopausal symptoms can then affect women's feelings of depression and anxiety as well. So we have to consider the whole woman, and the impact that all aspects of her life and what's going on with her health on the experience of her menopausal symptoms. Now we're beginning to understand what the mechanism of the hot flushes may be, but we still have a long way to go, and there's a lot of things that remain unclear. So again, in the hypothalamus, if you remember back to my earlier slide, as well as being the control of the hormones that control the ovaries, it also contains the temperature regulating part of the brain. And within our bodies, we have what's called the thermoneutral zone. So every day we have small variations in temperature which may occur after drinking a hot drink or a cold drink, moving from a cold room to a hot room, etc. And most of those times, these little small changes in temperature are not perceived by us. However, if we find that we cross a threshold for either too hot or too cold, that elicits particular body responses. Too hot, it precipitates responses to cool us down. Too cold, it precipitates responses to warm us up. Now, what we think is happening with menopause and estrogen deficiency is that this thermoneutral zone is narrowed, so that these normal changes that we saw, these little changes in our body temperature, which normally would not have produced any sort of response, now triggers our hot flushes with dilation of the blood vessels in the skin and sweating and that feeling of heat, or triggers a response so that it constricts the blood vessels, we feel cold and we shiver. There are certain drugs and chemical disturbances that can also contribute to this, and also underlies why some of the treatments that we use can help with the hot flushes. So disturbances in serotonin and noradrenaline can also affect the thermoneutral zone. Now this slide just shows you the frequency, so the number of women, or the percentage of women who experience different menopausal symptoms when they're taking different sorts of adjuvant endocrine therapies. So we have the aromatase inhibitors such as Arimidex or Femara, tamoxifen, and the GnRH agonists like Zoladex. And as you can see, they all produce hot flushes, or the GnRH agonists are often worse. The aromatase inhibitors are particularly problematic for producing vaginal dryness because of the very low estrogen levels that they're designed to achieve. And this reflects in the problem of painful sex as well. You'll notice that there are a number of other symptoms that are associated with these and problems associated with these agents. As far as psychological issues are concerned, we know that women with breast cancer have an increased risk of depression and anxiety, which actually improves in the years following diagnosis, but still persists in a significant number of women at 5 years post-diagnosis. And this is associated with decreased social functioning. The risk factors that are associated with psychological issues are obviously your disease status and what treatments you've been going through. If you have multiple menopausal symptoms, so the hot flushes, the night sweats, the insomnia, can interact and make you more likely to develop depression, anxiety, or may make it worse. We know that menopause as a result of treatment can impact on psychological health. Younger women who are going through menopause at a younger age are more at risk of psychological issues if you have multiple health problems and if you've had previous psychological treatment or psychological issues. As far as urogenital symptoms are concerned, there's a variety of symptoms that women might experience. The vaginal dryness, which I mentioned before, this can sometimes be women feel a burning or an itch in the vaginal or vulval area. They can have an increased risk of urinary tract infection, and sexual intercourse can be very painful. And as you can see, it's very common. It's also a silent problem. We know that fewer than 20% of menopausal women without breast cancer will just volunteer these symptoms to their doctor, and we think it's probably the same or even fewer women who have breast cancer. And again, there are risk factors for these urogenital symptoms. If you're having combined chemotherapy and adjuvant therapy, the aromatase inhibitors, and I showed you the frequency of vaginal dryness in that previous slide. Smoking is bad for all aspects of life, and obviously menopause with the associated estrogen deficiency causes these symptoms as well. Difficulties with sexual function are extremely common and affect all aspects of sexual function. So it can affect desire and libido, it can affect ability to become aroused, orgasm, and pain with intercourse. And obviously it can be very distressing to the woman and also to her partner, and can interfere with intimate relationships. As with menopausal symptoms, there are a number of factors affecting sexual function. We can't just focus on the hormones. We need to look at all of these different factors and address them all in turn or all together. As well as these symptoms that can be associated with menopause that I've previously described, we need to also think about the longer-term consequences of menopause. We know that 5-year survival rates for women with breast cancer are about 89 to 90% currently, and with continuing treatments are expected to increase further. So we need to consider the longer-term consequences of menopause as more women are becoming breast cancer survivors. If we consider cardiovascular disease, and I think that this is a very informative study. This was a study of women with breast cancer who are on average age of 60 years. And what they did was they calculated their risk of breast cancer recurrence, and they also calculated their risk of cardiovascular disease. And I think that it's important to note that in 80% of women, their risk of cardiovascular disease was greater or equal to their risk of breast cancer recurrence. So it's important to think about these longer-term aspects of menopause as well. Women with breast cancer have risk factors for cardiovascular disease. There are the potential effects of chemotherapy or radiotherapy on the heart. We know that women with breast cancer or following a breast cancer diagnosis and treatment actually gain weight. Usual average is 5 kilos of weight gain. And this is thought to be due to multiple factors. Women can have decreased physical activity, which may contribute to their weight gain. We also know that there is an increased risk with premature or early menopause. So premature menopause is menopause occurring before age of 40 years, and early menopause is menopause occurring before age of 45 years. And certainly in populations of women without cancer, premature or early menopause is associated with an increased risk of cardiovascular disease, and we think that this might be because of the beneficial effects that estrogen has on the heart and blood vessels. But we actually don't know whether this is the case with women who've had cancer. As well as cardiovascular disease, we need to think about bone health, and we know that bone loss is associated with various cancer therapies. So what this slide shows you is that this is the amount of bone loss in 1 year at the lumbar spine in different situations. So if we look at the woman with usual menopause, she'll lose between 1 to 2% of menopause of bone at the lumbar spine in 1 year. If we then look at women who are on aromatase inhibitors, they'll lose about 2.6% of their bone. And this increases so that we get to women who have ovarian failure secondary to chemotherapy, and they're potentially losing up to 7.7% of bone density loss at the lumbar spine in 1 year. And some of the risk factors that women with breast cancer have that may contribute to this bone loss is that we know that aromatase inhibitors are associated with an increased risk of fracture, although tamoxifen use is actually protective. Vitamin D deficiency is common in women at the time of diagnosis of breast cancer and in women who've previously had breast cancer. And in the studies that I described a moment ago, which looked at women without cancer with premature or early menopause who had an increased risk of cardiovascular disease, the data also suggests that they have an increased risk of fracture. Again, we're not sure in women with cancer whether this is also the case. So let's move on to management of menopausal symptoms. So as far as vasomotor symptoms are concerned, and these are the hot flushes and the night sweats that I described before, most women with breast cancer experiencing these symptoms were not receiving treatment. So treatment can be looked at from looking at the lifestyle or the environment point of view, and a hot flush diary may be useful to identify triggers, avoiding synthetic fibres, dressing in layers, avoiding the triggers such as spicy food, alcohol, hot drinks or hair dryers, caffeine, cooling the external environment by using fans or water sprays, and stop smoking may all be helpful. As far as specific medical therapies are concerned, there are a number of studies that have shown, clinical trials that have been shown that there are particular agents that are effective. So we'll start with the antidepressants. Venlafaxine, desvenlafaxine, escitalopram, citalopram and fluoxetine to a lesser degree, have all been shown to be effective in reducing hot flushes by about 60%. They also have been shown to improve mood as well. Desvenlafaxine and escitalopram have been shown to improve sleep. We cannot use paroxetine or fluoxetine in women who are on tamoxifen because it interferes with the bioavailability of tamoxifen. Escitalopram probably has the least effect on sexual function. All of these agents need to be started at low dose and gradually increased because of the potential of gastrointestinal side effects. Now, all of these agents are commonly used as antidepressants, but it's interesting that we see an effect on the hot flushes at about half the dose that is often required for their antidepressant effect. I use these medication in women who are having hot flushes and particular mood symptoms. It's how I decide on what might be the best choice for the woman concerned. If we look, gabapentin is an agent which is used as an anti-epileptic and also for chronic pain. It has a similar degree of reduction in hot flushes and also has the side effect of making you sleepy, so you get an improvement in sleep. It has less effect on sexual function but no effect on mood. Pregabalin is known as Lyrica and it's used in the treatment of fibromyalgia as well as chronic pain. And it again also has been shown to have this reduction in hot flushes. So if there is a woman who comes to see me and her main complaint is of her hot flushes which are disturbing her sleep, but she has really no effect on mood, then gabapentin or pregabalin might be a good choice. It's important to note that the use of these agents is off PBS. So gabapentin has come off patent. It's about $15 per month. We can prescribe these to some extent. They're off-label use for using in vasomotor symptoms, but because of the mood effects, we can still usually prescribe them on the PBS. Clonidine is the only agent which is actually on the PBS for the indication of hot flushes. But unfortunately, it's probably the weakest of the pharmaceutical agents that we have to reduce hot flushes, but it can be effective. It has a side effect of having a dry mouth. With all of these agents, we start at a low dose and we gradually increase until we get to a maximal dose or we get a desired effect. Now, as far as hormone replacement therapy is concerned, it is the most effective therapy for hot flushes, reducing them by about 85 to 90%. The problem is that there is a potential for an increased risk of breast cancer recurrence, particularly in women with estrogen receptor positive breast cancer. So we don't tend to use this unless women have tried everything else and they are counselled, and we have the agreement with their treating oncology team to have a trial of hormone replacement therapy, and the woman is aware of the potential increased risk of recurrence, or in those situations where the increased risk of recurrence is not so much of a predominant concern anymore, and really the quality of life for that woman is the most important thing. Now, non-drug treatments. There's been a lot of interest in this, and there's been a lot of studies conducted of variable quality. However, we are beginning to have options for effective non-drug treatments. So cognitive behavioural therapy, or mindfulness, has been shown to reduce the nuisance or bothersomeness of vasomotor symptoms by about 30 to 40% at 6 months, and was associated with improved mood, sleep, sexual function and quality of life. And there are a number of apps and websites that have got mindfulness programs on them that you can avail yourselves of. Acupuncture is thought to be associated with a 40% reduction in vasomotor symptoms, but it's important to know that this is operator dependent, so you need to have an acupuncture therapist who is used to managing vasomotor symptoms, but it can be certainly a reasonable option. With hypnosis and stellate ganglion blockade, there's been one study of stellate ganglion blockade and a variety of studies of hypnosis of variable quality. So we can't definitely say can't have a definite point of view regarding their effectiveness, but they're certainly promising, and it's a sort of a watch this space. Further things with respect to watch this space is there was a pilot study of magnesium which looked promising, but unfortunately when they did the bigger study, it was no longer thought to show any particular benefit over placebo. Other things that are looking possible is the use of folic acid, the use of paced respiration. There was one study which showed that 10% weight loss in women who were obese, they reported a decrease in their hot flushes, in their vasomotor symptoms, and also yoga looks promising as well. Now, as far as some of the other complementary therapies are concerned, there was a question regarding soy. So where soy preparations have been shown to be effective probably for mild hot flushes, and we know that in those populations of women who have a lot high soy intake in their diet, such as some of the Asian countries, particularly Japanese women, they have a reduced risk of breast cancer. When they've actually done studies in the laboratory with soy and breast cancer cell lines, there's been mixed results. So we actually don't know whether the amount of soy that you have to take to relieve your hot flushes is actually safe in breast cancer. There appears to be no effect with respect to vitamin E and omega-3, magnetic therapy, homeopathy. There is certainly some studies which suggest that some herbal preparations may be useful, but again with the soy, we don't know about their safety in breast cancer. There are other concerns such as black cohosh has been associated with liver abnormalities, and their effect on hot flushes is at the best limited and much less than those pharmaceutical agents that I showed you before. As far as yam cream is concerned, I'd put that under this is another question, I would put that under the category of the herbs. There's no evidence that it is safe. There has been some evidence to suggest used in women without breast cancer that it's actually not very effective anyway. As far as bioidentical hormone replacement is concerned, which is compounded hormone therapy, the concern about these preparations is that they often contain estrogen. And an estrogen is an estrogen, whether it comes in a compounded hormone therapy preparation or it comes in an HRT tablet or patch form. It can still be associated with the increased risk, potential increased risk of breast cancer recurrence. Just because it's bioidentical and compounded does not mean that it's safe. We certainly know that in women without breast cancer who have taken bioidentical hormone therapy, there have been reports of endometrial cancer in these women, which are exactly the same potential side effects that we see with conventional HRT. So I would not recommend using that at all, and particularly not in the setting of breast cancer. As far as urogenital symptoms are concerned, we need to exclude any infection or sort of superficial skin problems. Lifestyle modification can be helpful. Sexual activity is actually, if it can be tolerated, can be useful in maintaining vaginal elasticity. The problem is if you have sexual activity when you have a very dry vagina which has, I hate this word, but has atrophic change, so it has severe estrogen deficiency, what can happen is you can actually set up a sort of a neuropathic response so that you actually get ongoing pain, and then you need really referral to a pelvic physiotherapist and actually almost a desensitization sort of treatment combined with the use of vaginal moisturizers. Vaginal moisturizers such as particularly Replens, they're not as good as vaginal estrogen, but they can be helpful for, they're a non-hormonal way of providing moisture to the vagina over a 24-hour period. The thing about KY jelly and some of the lubricants that are available for sexual intercourse, they only provide lubrication for about an hour. Now that's fine for most sexual activity, but for vaginal dryness over the longer term, you need a specific vaginal moisturizer. As far as vaginal estrogen is concerned, vaginal estrogens really have very minimal systemic absorption. So requires discussion with your oncology or breast cancer treating team, but particularly if you're using tamoxifen or if you're not on a aromatase inhibitor, then use of vaginal estrogen can be permitted for urogenital symptoms. Usually, however, if a woman is taking an aromatase inhibitor, because of the very low estrogen levels that are desired and achieved with an aromatase inhibitor, even that minimal absorption with the vaginal estrogen can be an issue, although it's usually only an issue for the first 2 weeks of treatment. After that time, when using a vaginal estrogen, the cells of the vagina have rejuvenated to some extent with the use of the estrogen, and now they form an impenetrable barrier. It's only when they're very atrophic that they allow the absorption of the estrogen into the circulation. Sometimes what we need to do is change from one form of adjuvant endocrine therapy to another. As I showed you in the slide before, there's less vaginal dryness with tamoxifen. Now, sexual function difficulties are a huge problem and can be very difficult to manage. And women and their doctors may often have difficulty discussing sexual problems. We need to treat the urogenital symptoms, particularly if if a woman develops that problem of the pain with intercourse despite the vaginal dryness being relieved. We need to think about what medication may negatively be impacting on sexual function, and it's often good to see a specialist, such as a sexual therapy clinic or referral to a menopause clinic. The other thing is that Cancer Victoria, you can ring their helpline, and they can organise appointments with a sexual therapist over the phone. So that might be an option if you don't want to go to one of the clinics. As far as other treatments are concerned, there's still a bit of a lack of evidence. There was a study with testosterone treatment, but it didn't show any benefit, and there is concern regarding safety. If you're not on an aromatase inhibitor, the way we get estrogen in the body is it's made from testosterone. So the concern would be that any testosterone that you have could be converted to estrogen in the body. There's been a pilot study where women used intravaginal local anaesthetic gel, and that helped with pain with sexual intercourse. But again, we need a little more research before we can sort of recommend that to everyone. And the role of other medications such as Viagra is really unclear with respect to sexual problems in women either with breast cancer or without breast cancer. As far as the longer term consequences of menopause are concerned, with cardiovascular disease, it's important to maintain a healthy weight range, exercise, stop smoking, make sure you're screened for, and if your cholesterol levels are elevated, have them treated by dietary or if necessary tablets, and screen for and treat any diabetes. As far as bone health is concerned, ensure you have an adequate calcium intake. Need about 1,200, postmenopausal women need about 1,200 milligrams per day. So that's about 4 serves of low-fat dairy products. So a cup of milk, tub of yogurt, ounce of cheese is equivalent to about 300 milligrams of calcium. Weight-bearing exercise is important, and adequate vitamin D. Vitamin D is thought to be important both for helping to assist in calcium absorption from the gastrointestinal tract, but may also be important with muscle strength and balance. If you are commencing an aromatase inhibitor or have risk factors for osteoporosis, such as a family history of osteoporosis, you've previously had a minimal trauma fracture, you've had to have steroid glucocorticoid therapies, you have a very low body mass index or have malabsorption problems such as celiac disease, then you should have a bone density test to determine whether that will help to sort of determine what your risk might be for fracture. There are certainly specific osteoporosis treatments available, and your GP can refer you to a specialist for further management with respect to that. These are some very useful sites and that they have information. I think that this cartoon is very relevant in that there are a lot of websites of variable quality, and I think that you need to be very careful in what you look at. These are well recognized and reputable sites that you have got menopause information on them, and also tips about midlife health and calcium, etc. And Melbourne is very fortunate and it actually has 2 public hospital multidisciplinary clinics which have got clinics operating specifically for women who have a cancer diagnosis, both at Monash Clayton and also at the Women's. The other thing to note is that there is a Find a Doctor site on the Australasian Menopause website, and so they have doctors who have an interest in menopause and women's health, so that would be another option for you to seek. And finally, I just want to comment about hopefully I've answered most of the questions that were given to me. There was one question regarding what dictates choice between tamoxifen or an aromatase inhibitor, and what is the rationale for 5 or 10 years. I think that that is actually a question for the oncologist or the breast cancer treating team. Sometimes the experience of menopausal symptoms can impact on the choice of the treatment. There are some women who will have a month off their treatment to see whether or not their symptoms improve, who will swap from one to the other to see if their symptoms will improve. But the actual specific choice or duration is really something that the oncology team determines. The only thing that I would say is that in women who have had CIA and they're not specifically postmenopausal, they haven't had their ovaries removed, then tamoxifen is used preferentially, because there's concern that the use of the aromatase inhibitors in women who still might have some ovarian function may precipitate ovarian function and a rise in estrogen, which is not deserved. And I think at that point I'll finish. So thank you very much for your attention.
Thank you, Amanda. It's Robin once again. I'd really like to thank you for being part of what is our first webinar. We've been very excited to hold this evening, and we really do thank you for your participation and providing such an informative presentation. So thank you. I would also like to thank once again Jennifer from Toshiba, who without her here we wouldn't have managed quite so well, may I say. So we're delighted to have her here. So on behalf of myself, Robin, Michelle, and also Bronwyn, I'd like to thank everybody for being part of this webinar. I see we're finishing a little bit early, but that's a good thing. So thank you once again, everybody, for being part of it. Thank you.